morning, everybody. I would like first to thank the Society for inviting me to give this lecture. It's nice to see my old friends today. So it's a big subject in a short time, so I'll go a little bit quick. Okay, so glucocorticoids, they have direct and indirect effect on the bone. So the summary of the direct effects that there is decreased bone formation and increased bone resorption leading to bone loss. The indirect effect is through the decreased intestinal calcium absorption, increased renal calcium excretion. This will stimulate PTH and bone resorption will be activated. Also, there are other causes that may contribute to bone loss like hypogonadism, reduced production of IGFs, and myopathy with increased risk of falling. So all this will increase the risk of fracture, and added to that is the disease activity that the steroid was giving for, the physical disability that comes together, and elevated inflammatory cytokines. And this is mainly, of course, we see that in rheumatic diseases. So if patients receive glucocorticoids in other forms like intermittent or alternate days or pulse therapy, with intermittent there is less effect. With the glucocorticoid on alternate days, it may preserve growth in children, but it does not prevent bone loss. With pulse glucocorticoid, there is less effect on bone density compared to continuous treatment, but there is increase in the risk of osteonecrosis. But don't forget that steroids, they have protective effect because they suppress the underlying disease activity, and this will protect the bone from bone loss. So it's not all like doing harm for that. Now, there are a lot of risk factors that are related to GIO. Some of them related to the steroid, mainly the dose and the duration. Some are related to the underlying condition. And mainly we always say rheumatoid arthritis is the worst in the effect on osteoporosis. And there is, risk related to osteoporosis itself. Risk factors like the age and being post-menopause. When patients take steroid, they lose bone maximum in the first 3 to 6 months. They lose even about 20% of their bone. And then it reached like a plateau or a slow decline. And then when steroids are stopped, there is a gradual increase in bone density, which may take up to 6 months or 1 year. And this is if patients stop treatment, which does not always happen. The risk on fracture the risk of fracture, of course, is related to dose. So the doses for certain, 7.5 and more, they cause significant bone loss. There is some evidence about bone loss with smaller doses, but it's not very strong. But it's mainly the dose with increased risk of fracture, of course. So the risk, again, increase according to the dose. If you look to electron microscopy in the bone, that is for these patients, you will see that there is low trabecular number and plates, increased trabecular separation. So the increased risk of vertebral fracture is because of the greater effect on trabecular bone rather than cortical bone. And there is, of course, mainly marked depression of osteoblasts, whereas in the usual primary osteoporosis, the postmenopausal, there is very little decrease in bone formation, but there is activation of bone resorption. So it is not the same mechanism like in postmenopausal osteoporosis. Now, the fracture risk in patients on steroid, when you compare to patients who are not using steroid, happens mainly because it alters the bone density fracture threshold. So these patients, they tend to fracture at a younger age, at a lower baseline femoral neck and lumbar spine bone density, with less number of prevalent fracture. They have much more risk of a new vertebral fracture, and in general, the risk of fracture increased by more than 6 times. Now, there are some issues in diagnosis and management. First of all, if you have access to trabecular bone score, you have to use it because it is superior, like in primary osteoporosis, it is superior to DEXA scan. Also, if you are using the FRAX tool in these patients, you have to make adjustment for these patients because the FRAX tool may underestimate the actual fracture risk in people on high doses or overestimate the risk in people on lower doses. So there is, like a protocol on how to adjust that. So you add it to the risk, you increase by 15, 10, 25% according to the age of the patient. The studies on GIO, on medications, the number of fractures in these medications are small. So the analysis, it had very little power to detect difference in the relative risk of fracture in these studies. The treatment studies was relatively short. Maximum probably is 2 years in these studies. So the certainty of evidence based on any medication that you are using in GIO is either low or very low. You don't have very strong evidence for all medications. Always, of course, we'll not go through that, the non-drug treatment in these patients. At the end, we will go through the guidelines. But first of all, these slides will just make you understand more the guidelines and how they are based from the beginning. So, and calcium, vitamin D, you will find it in the guidelines, the doses. I don't think we have to discuss this. What about gonadal hormone replacement? So patients, they can have hypogonadism because of steroids. So do you treat it? Do you depend on that to treat osteoporosis? Of course, in females, the WHR trial exposed the risk of long-term HRT, so we are not using it because there is benefit, but the risk is more than the benefit. In males, there is no strong evidence to support that the use of testosterone is beneficial in fracture reduction. So until now, it is not used in this, even with hypogonadism. So that's why if you look to the list that is put from in the ACR guidelines, you will not find a space for HRT, either in men or in women, because the evidence is not very strong. So now we'll go through the main medications in GIO. Bisphosphonates, of course, always when you have a lot of medications, a lot of studies, it's better to go for meta-analysis or Cochrane system review. They will give you the summary of all the studies. So according to the Cochrane review, at that time, it was done on 18 trials with more than 1,500 patients. So there was reduction in vertebral fracture versus placebo, with improvement, of course, and there was risk of non-vertebral fracture risk, which was not statistically significant. So the bisphosphonates in general, there is a good evidence that they decrease vertebral fracture, but not non-vertebral or hip fracture. So, and it's not always because the drug is not beneficial in this group of patients or in this type of fracture. It's because the hip fracture usually occurs in much severe cases at an older age. So if the original number is not very high, it's difficult to get a statistically significant result with that. So, but it doesn't mean that it doesn't work. Zoledronic acid was compared to risdronate, and of course it is superior as expected. What about denosumab in these patients? Denosumab is superior to risdronate, just like primary osteoporosis, for increase in bone density, and the vertebral fracture increased after stopping. This is a very important point when you stop it. So if the patient can use it, it's better to use it. It is superior to bisphosphonates. But if you stop it, just like primary osteoporosis, after 7 to 9 months, you should expect increased risk of refracture. So you have to give something else after that. What about regarding teriparatide? Again, it decreased the incidence of vertebral fracture, but there is no evidence that it decreased the hip fracture. And the good thing about teriparatide, that bone density continues to increase even when the drug is stopped. So this is very important, although we always say still that you have to give another treatment for that. And the appealing point of teriparatide is that it is the only drug that reverses the pathophysiology of steroid. Because as we mentioned, steroid, they decrease bone osteoblast or bone formation. So the only drug which antagonizes this is teriparatide, not like the other medications which mainly work on anti-resorptive. So they are better used in postmenopausal women. Also, in patients who develop AFF or atypical femoral fracture, most of these patients, they are on steroid. And we'll not go through the AFF and what is it, but just to know that if you have patient with AFF, mainly it means frozen bone, the underlying pathophysiology. So the best treatment, just like primary osteoporosis, is to give teriparatide in these patients, although it's not approved either in primary or secondary osteoporosis for this indication, which is AFF. And it should be, there are a lot of expert opinions both in primary and secondary osteoporosis that teriparatide should be considered as first-line therapy for those at very high risk, like very old patients who are starting very high dose of steroid, multiple previous fracture, very low initial bone mass, less than -3.5, and this is of course in patients in primary osteoporosis. So probably -3 is indication to give teriparatide in GIO, and it may be even cost-effective in these patients. It is superior to alendronate, of course, as expected, in decreasing vertebral fracture and non-vertebral fracture. Regarding romosozumab, there is only one ongoing phase 4 trial comparing Romo to Dino for the treatment of osteoporosis in long-term users. We don't have the results for that yet. What about patients with GIO who have been treated for a reason with bisphosphonates before? Here, teriparatide is superior to denosumab. It increased the bone density in all sites, not like denosumab. So it is superior in patients with GIO who have been treated with bisphosphonates in the past. Also, the other thing is that the therapeutic effect of denosumab in patients who are previously treated is blunted, but with teriparatide, there is significant increase in the bone density, as we mentioned. So it is superior at all levels. Now we go to the guidelines, which were published in 2017, and then there were some update in 2022. So first of all, you have to get familiar with the terms that have been used in these guidelines. So they are a little bit different between the young and the older patients, which is 40 years of age, more or less than that. So major fracture is the same. In the clinical fracture risk assessment, no fracs, of course, for the younger patient. So the same factors, apart from no fracs used in younger patients. Also, again, in the follow-up, you use fracs and bone density in older patients, but no fracs in younger patients. And the fracs correction is not applicable, of course, in younger patients. So you start with risk stratification. Any patient who is planned for a long-term steroid, you start with bone density, which is recommended to be done within 6 months of starting the steroid therapy, and then every 1 to 2 years, therefore, when patients on treatment. So it's always get used to doing bone density initially when you see the patient and decide to give them long-term treatment. These are the clinical risk factors that you have to consider during the assessment. Now, regarding the categories of patients, it can be either high risk, moderate risk, or low risk. So there is, again, a little difference between the young and the older patients. In younger patients, you use the same risk factors: prior osteoporosis fracture, steroid dose more than 30, or cumulative dose more than 5 grams per year. But of course, there is no space here for bone density or fracs tool in younger patients. If patients, they have this risk factor, the younger one, they are considered high risk. If they don't have it, then you will go to do bone density, and then based on that, you can categorize the patient, either moderate or low risk. With the older patients, you will just use fracs for the moderate risk category. Now, the younger patients, they are considered moderate risk if they continue treatment for more than 6 months, more than 7.5, and they have PIP or spine Z-score less than 3. Or if they have rapid bone loss. If you do DEXA scan for them, it's okay, and then you repeat it. Sorry, what happened? And then you repeat it, and there is significant bone loss, more than 10%. This is moderate risk. Any patients who don't have any of these factors, they are low risk. Probably it's difficult to remember this table unless you get used to it, but it's better to put it always in your pocket so you can use it when needed. When you look to the recommendations of the medications, you will find strong recommendations and conditional recommendations, and this is based on the evidence that is available. So of course, always it's more favorable drug. I mean, this is what means by strong recommendation. Now, regarding the treatment, the only difference here is that in younger patients, there is no strong recommendation because the evidence is not strong like the older patient. Of course, because the older patients, they have higher risk of fracture. So in older patients, first line, strong recommendation for oral bisphosphonate and conditional recommendation in other medications, and against ROMO or SERM. In younger patients, there is no strong recommendation, but it's conditional recommendation for all medication. And against, again, ROMO and SERM. So just, classify it like this, and then look at it like this, because it looks confusing in the beginning. And then you will remember. So with or against. To make things easy, I tried just to squeeze the risk stratification and the treatment recommendations in one slide. So maybe it's a little bit easier if you just can capture it and then you can use it. But of course you have to go in details first in the guidelines that are published. So this will just give you a clue what to do, because otherwise it's easy to forget. What about sequential therapy? It's like primary osteoporosis after teriparatide or denosumab. If you stop, there is always bone loss. You don't stop. After bisphosphonates, okay, you stop, you take drug holiday. So the same here applies for sequential therapy in patients on steroid. So if the glucocorticoids are stopped and the patient, you have to reassess the patient, are they low, moderate, or high risk? So if the patient is at low or moderate risk, you stop bisphosphonates. You don't need anything after that. But if they are on PTH or for some reason ROMO or DINO, these medications you don't stop, and of course you don't continue for a long time after that because you stop the steroid. So you give it like for 1 to 2 years, just to make sure that they don't lose bone after that. Patients who remain at high risk, they continue treatment therapy or switch to other treatments. You have to continue treatment even if you stop the steroid. And using 2 different osteoporosis medication at the same time is very limited. Probably the best evidence is using teriparatide with the denosumab. This is the best one. What about follow-up treatment? How do you define the failure of treatment? The failure of treatment for older patients, if they fracture 18 months or more after beginning treatment with oral bisphosphonate, or if there is significant decline in bone density. So you have to know what is the definition of fracture, of failure of treatment. So if this happens, you will switch to another medication. So if this happens, you have to switch to either teriparatide, denosumab, or ROMO. Okay, if you, or sorry, orzoledonic acid or ROMO if you are stuck, which is, I don't think it will happen. In moderate to high fracture risk, if moderate to high fracture risk persists after bisphosphonate therapy, in these adults who are continuing, you have to continue treatment, of course. Whatever treatment you choose at the time, but you have to either continue bisphosphonates or switch to other medications. You have to be careful. Okay, خلاص, one slide only. Regarding the vertebroplasty or kyphoplasty that has been used in patients for chronic spinal pain, if they have fracture, we always say that even primary osteoporosis, they have risk of refracture. But in GIO, they have more risk of refracture, 2 times more increased risk of refracture in these patients. So you have to be careful when you do this procedure. Thank you.